So I just wanted to thank you all for coming and welcome you all to our community conversation here around the IHN-CCO. And we have all the fans going and trying to make things a little more cool in here, so we appreciate you all hanging in there with us. First of all, I wanted to let everybody know that we have Anna here who can help us with translation, and she's going to translate this for me. But if you need translation services in Spanish, if you could go over there and see Anna, she will fill you in, but she needs to say that in Spanish.
¿Se encuentra alguien aquí que necesita alguna traducción en español? Nos vamos a reunir en aquel rinconcito. If somebody in here need translation in Spanish, we're gonna be there over there.
Okay. And one more thing is the restrooms. Thank you. The restrooms are right here if you're looking for that, and please help yourself to the snacks and the water. And so we're doing it a little bit different this time. If you've come to these before, we've had a table up here with people sitting at them, and so we're trying a little bit of a different approach to see if that's more of a conversation. And so I'm going to go first. So my name is Kelly Kaiser, and I serve as the CEO of InterCommunity Health Network. And I think, first of all, my plan originally was to get up here and talk about some of the wonderful successes that we've had over the last 3 years as a CCO, and I'm still going to do that. But I thought I would open up with a few comments about our quality metrics, because those did just come out in the last 10 or so days, and I'm guessing from the nodding in the audience that some of you have seen that or seen the articles that were in the paper, and wanted to just comment on that right up front and make sure that I had a chance to answer any questions you had about those. I'm not going to say anything different than I think I've said as it related to the public comments we made. I don't believe that those metrics are a reflection on who we are as a CCO or the successes that we've had as a CCO. Our approach has always been one around transformation that's sustaining and actually changes and meets the outcomes for our members that we're after. We have not necessarily focused specifically on the very specific pieces that are related to those metrics. Not that that's right or wrong, or I'm making excuses for that. I'm just saying our approach has been one that's been more of a long-term, sustainable, transformational change. And so we did not meet the minimum required metrics in order to receive the full funding. We did meet a number of them that I think we should be very proud of as a community and all be part of. And I wanted to point out one thing that wasn't in, that isn't as obvious. It's in the full report from the Oregon Health Authority, which I'm guessing a number of you in this room have seen. But there is one measure on there that is not a financial measure. It's a quality measure that isn't a financial measure, and it's on health status. And it's the self-reported health status. And I think it's important to note that our CCO has the highest self-reported health status. Our members in our CCO has reported on a statewide basis the highest status of health status. So we didn't ask this question, the state asked this question, so we weren't involved in this. But the question was, I'll read you the question. It's the percentage of members who report their overall health as excellent or very good. And so our CCO for children and adults had the highest percentage and the highest increase. So I would say that in my mind, that is a long-term sustainable piece of this puzzle that I think is important to point out. It was not one of the financial metrics, so we did not get credit for that. But I think it speaks to the underlying approach we've taken as a CCO with all of our partners around transformational change that's sustaining moving forward. So I wanted to just say that, and I'm happy to answer any questions. I'll repeat the question in a second. So the question was around, I think, let me summarize it, this report that I was speaking to, is it broken out by county, and are there different answers based on each county? And what I would say is this has nothing to do with this one is for anybody who's in IHN-CCO, it doesn't matter where they live. And I would tell you that the majority of our membership is in Lynn County, so if you think about sort of a weighted average, in theory, Lynn County would have a higher weighting in that. So, yep. Yep, Sam? So did everybody hear that? I can repeat it. So the question was, were we surprised when we got these metrics, or did we sort of anticipate some of this was coming? And given that we're halfway through 2015, how are we doing? So those are great questions. To the first question, I would say we actually were a bit surprised by there's a number of these metrics that we don't actually track. So we didn't know about them till the very end. And two of them were those they're called the CAPS metrics, so they're the metrics where the state calls members and asks them their feedback. So we didn't have that information. We met those two metrics last year, so we were assuming we would meet those metrics this year as we felt like things were the same. Those were two metrics that we did not meet. So to your question, those ones were a bit of a surprise. I will say the good news is of the 7 metrics we didn't meet, on 4 of them we improved over last year. So we did better than we did last year. It wasn't enough, not saying that, but so that was a bit of a surprise. At least on those, there were 2 or 3 that were not data we submit. They come from other sources, so those were a bit of a surprise. So we're continuing to focus and understand what we can do to be involved in those more for 2015. In terms of 2015 and moving forward, there were certainly some that we know are challenges. They're challenges statewide. And so we've been focusing and having different outreach on those as we move forward. A little bit of the challenges that are details around what we need and the specs related to 2015, we didn't get those till the first quarter of 2015, like the end of the first quarter. So, and then a lot of this data comes from the claims that we get, and there's a lag involved in that. So we're just now getting our first quarter summary to see how we're doing. That's due in the next couple weeks. So we will very much be taking that as our beginning place to make sure that we are successful in 2015 moving forward. What else? You got me, I'm right here, I'm ready. Okay, Betty. I'll just repeat it. Sure. Sure. Yeah. So the question was, are there some we're really focusing on, and what are the steps we're doing to really make that better in the future? I think there are some that are more simple than others, to be honest with you. Some of them are around which code you use or which code the provider uses when they see a patient. And both codes are technically good codes, but only one code counts in this metric. So we believe from an outcomes perspective, the care was provided and the goal of what we're trying to do was met, but it wasn't met with the right code. And so we didn't get credit for it. That's kind of one example. Now, everybody else did that. Again, not making excuses, just saying those kind of things where that's something we can really focus on and try and work with our providers and with their electronic medical records. And here's the code that the state needs you to use, and please use this one and build it in so that it's just happens. So that would be one example. We were talking a little bit earlier about what can we do, what can we ask all of you to do, our Community Advisory Council, our stakeholders. You know, some of the areas where we didn't meet were on the SBIRT screening, which is this screening, brief, intervention, and referral to treatment. So when you go to see a provider, if you're interested, say, did you give me my SBIRT? Remind them so that is a preventive measure that is useful to do. And again, we're trying to build that into the electronic medical record. Adolescent well-child visits. That's one across the state that has been a challenge for all the CCOs. So, you know, finding time to get your teenager to go in and have their, or even younger, well-child check. encouraging those that you know or those family members to get that preventive care in. So those kind of things are helpful, and those are some of the things we're really targeting and trying to send out different notices to remind patients to go in and to providers to remind them to reach out and do that. So those are just a few. Yeah. I'm sorry. So that's a great example of sort of one of the challenges that we're in the middle of, and especially as we know, and you all know, access is a challenge. Whether you're on the Oregon Health Plan or not, it's a challenge to get in. And I have to admit, I don't know the exact answer to that in terms of what is the appropriate statements from the appropriate college on how often you should come in or not and how that fits in the metric. But I think that's a great example of, are we all aligned in the same way and trying to do the same thing? And that's something I will look into. But I don't have a specific answer to that, but that's a great question. Well, and that's kind of what Betty said. So the question was, she heard, the feedback she got from her pediatrician was to come in every other year, not every year. And so if we're getting graded, for lack of a better word, on it happening every year, we're giving two different messages to the patient, which is not helpful. So that's something that I would need to check on for sure. It's a great point. Yeah. Sure. Yeah, great point. So the question was, since a number of the other CCOs were successful in meeting their metrics, and again, just a quick reminder, you had to meet 12 out of the 17 to get 100% of your dollars. And some met 16, some met 17, some met 12, some met 9.9. So it's the whole range, and you had to get that medium. And Judy's question was, what can we learn from other CCOs that were more successful? And that is absolutely the case, and we're continuing to talk about that and have been in different ways. And sometimes it's a different answer in a different community, and sometimes it's the same answer in the same community. So we continue to talk about that. I don't have anything right off the top of my head, but we are definitely trying to learn from each other what is a successful outreach and how can we make things improve. Yeah. So the question was, what are we doing to reach out to our members and see what we can ask for their help in helping us change and improve the care we're delivering, not necessarily maybe just the metrics, but in general, what can they do to help? And I would say that's a great question, and one that we are constantly working on with the CAC and the local CACs, trying to figure out what they can do to help. And again, I think we are open to, whether it's the metrics or the long-term sustainable transformation, we've always been open to what they can do to help. It's hard for me to come back and say to you, do this, because it may be something different in each area. But if we have some tangible things, especially related to the metrics that we need help with, like please tell anybody you know to make sure they get their well child checks, whatever the right timing is, or whatever those pieces are, that's certainly something we would want to do. But I think that makes it harder. We're trying to engage our members more by having these meetings and having food and having some childcare and other ways. If you have suggestions on better ways to reach out to members, I'm open to hear those.
No, I'm open to hear. I want to hear your ideas, not mine.
What I can do to reach the members? But my sense of what you're saying is my ideas aren't working because we tried letters and we tried calling them and we tried those kind of things and we're still not getting them very good. So I guess I would flip that back on you and say what would be useful? What would you think a member would listen to? So, because we're open. Okay.
What I'm trying to figure out if IHN-CCO is doing anything besides what we're hearing about here.
Yes, so that's what I was trying to say. Yeah, so the question was, what are we doing to engage our members in their own care? Is that the correct question? So I think some of that is some of the information that we have around here around outreach, the different, your mental health, kind of the outreach pilot that we've been doing, trying to reach out to them. I think there's a number of different things that we do in terms of sending notices and reminders to members to remember to do these things. I guess my question back to you was, they don't always read them or listen to them, so is there a different way we could be reaching out? I'm open to that, but we do try a number of different things, whether it's phone calls, mailers. We've done a public marketing campaign around reaching out and engaging in your health and your mental health and your wellness. That's been all over, especially Lynn County. So we've done a number of different things, but I think my underlying thought is what you're saying is it's not, maybe isn't working as well as we would like, so what else should we do? And we agree, and we're open to that. That answer your question? Better? Okay. All right, one more, and then I wanted to talk about some of the things we are doing. So are you new? So the question was, she's saying that she is an OHP member and she hasn't gotten a lot of information from us. So can I ask, are you newer to the plan or have you been on the plan for a while? All right, good feedback. She's been on for a couple of years and is not getting a lot of things. So that's important for us to hear and make sure that we look at that. I don't have an answer off the top of my head for that, but that's good feedback. And Rebecca would like to recruit you for the Community Advisory Council, and she's going to get you afterwards. Okay, really quick, because I want to give others a chance to talk, but I did want to just talk about, at our last meeting that we had in Benton County, there was some feedback around talking through some of the things that we've been doing and what we've been successful at, some tangible things. And so there's a number of those, and you have a number of handouts, and these handouts, some of them talk specifically about things that we as the CCO and all of our partners have done. Some of them talk about things that the counties have done that we get to be part of. They're kind of all across the board, and you're going to hear some more around our transformation in a minute. But I think there's a number of things that are actual specific things that I think have really helped members, and I'm just going to talk about one really quickly, which is an administrative crisis response team. And this was developed to support the needs of our members that are in child custody. And basically, it was it's a collaboration between the counties, the CCO, child welfare around enrolling those kids in our plan and making sure that we reach out to them from the very beginning and figure out what's going on and get their services and get all the pieces in place as they move forward. And so I have kind of a whole written summary on how that works, and we have some success stories on actual cases that has happened. And I think one that I wanted to read to you was we had a 12-year-old who was placed in treatment foster home in a different county, not in our service area. The request was made to have this enrollment switched back to us because they were in the wrong area. The request was received and processed on the same day. The member was retro-enrolled back into our plan, and the transition to the care happened right away. So we were in front of it because we were all working together, not because of any one party, but because we were all working together to meet the needs of that child who was getting moved around a lot. And so we were able to successfully kind of wrap around them and give them the direction they needed in the current care they were in. So that's one little example, and we do that with with the foster kids that come under our plan. As long as we have that upfront notification, we work with them and try and surround them and make sure they get what they need. So that's just one simple example of some successes, and you'll hear more of those as we move on, but I wanted to make sure I had a chance to have some others speak. So we've asked David Trebus here, who is a board member on the IHN Board of Directors, and wanted him to just give a few minutes on the role of the Board of Directors and how it functions and what its responsibilities are. And then we've asked Dr. Eby to come up and talk about the Community Advisory Council and its role. And then we've asked Ralph Wyatt, who is a Lynn County Administrator, to come up and talk about the role of the Regional Planning Council and as well as the county and how they fit into all these pieces. And then we're really going to open it up for questions. And I have questions from some of you. If you want to not ask a question in person, we do have notes and you can write them and we'll read them and work on answering those. So first I'm going to turn it over to David.
Thanks, Kelly. I have a loud voice, so is this okay? Okay. As Kelly mentioned, I'm Dave Trebus. I'm with Samaritan Health. I'm a vice president with Samaritan Health, and I'm the vice chair of the IHN-CCO board. And I do want to give deference to the folks that are doing the lion's share of the work in consideration of some of the questions I've already heard today. So what the role of the board is when we embarked on healthcare reform in the state of Oregon, we created CCOs, and at a state level, Samaritan and a group of other stakeholders decided that we would form a CCO. So the board is charged with making sure that we're adhering to the responsibilities and duties that we have under the state mandated reforms that are going on. And we're supposed to do it in a way that connects us all together. And that's what we try to do as a board. The board is composed of community members, of stakeholders, of providers, and those community members are from all three counties. So we have Lynn, Benton, and Lincoln County representatives on the board. And we also work, when I say the people doing the lion's share of the work that the board oversees, it's really the Community Advisory Council and the Regional Planning Council that are connecting on a very regular basis with the communities that we serve and bringing things forward to the board, as well as the community members on the board that are helping us with all that. So we have a contract with the state of Oregon, and that contract again lays out the responsibilities that we have, so we're responsible for administering that. And part of our responsibility is to connect with all of you. And so this is, Kelly, is this like our third meeting over here? I think? Third or fourth meeting. And so it's our focus to be able to continue to connect with each of the communities that we have partnership with people, and then move the CCO forward that way. And I won't talk about the role of the Community Advisory Council and the Regional Advisory Board. These two gentlemen are going to do that for me. Kelly, are there any things that you'd like me to highlight as a board member? Okay, then I'll have Dr. Larry Eby, come up and talk about the Community Advisory Council. Here you are, sir.
Before I talk about the Community Advisory Council, I'd just like to ask you, how many of you are not acquainted with the term patient-centered primary care home? How many of you are not acquainted with that term? Or how many of you don't know how it really is supposed to work? The reason I'm asking that question, even though it's not really my topic, is that the question was asked about how Samaritan Health, how the CCO engages with the client, the patient, in terms of, like the question Gary asked, how does the organization engage with the client patient in terms of being involved in their health care? Well, ideally, in the best of all worlds, everyone under IHN-CCO would be enrolled in a patient-centered primary care home. And those homes, when they're functioning well, will actively there'll be a two-way engagement from the medical home to the client and vice versa. And so a lot of these questions that come up are, the answer is sort of built into that relationship. Given the far-flung way and the convoluted way in which medical care has been carried out in this country and in this area in the past, that doesn't happen easily and automatically. So it requires quite a bit of work. And I think it does relate to the activity of our council in that we advocate for, we are patient-client advocates. And that includes being concerned that they are engaged in such things as patient-centered primary care homes, that they get good feedback on their care and all the things that we would like to see happen. But now actually, well, first of all, the organization that I chair is called the Community Advisory Council. Not too many of our members are here, but Frank Moore was there. There he is. And Joe Czar from Benton County is here. Help me. Liz Bear is on, well, she brings up something. She is on the Lynn County Advisory Committee. Dick Knowles is on the Lynn County Committee. Sam Sappington chairs the Benton County Committee. Who else? Help me. Pat Neal is on the Regional Advisory Council representing Lincoln County, and I think I saw someone else. Judy Ball is on the Benton County Advisory Committee, and most, not least, as Rebecca Fowler, right back there, she does all the hard work for us. She is our coordinator, and she really works hard at helping us. I don't have anything as engaging and sexy as the other speakers do, because I don't deal with money, I don't deal with influence, very much influence, and what are the other things? Well, I don't deal with pilot projects, which Kim is going to talk about. I just deal with advising. Now, how does one advise? The responsibilities of the council are well defined by the state, and they are in our charter, and I'm going to bore you with reading some of it. They include but are not limited to identifying and advocating for preventative best care practices and innovative approaches to be utilized by the IHN-CCO. And that is done through primarily through overseeing a community health assessment plan and adopting a community health improvement plan to serve as strategic population health and healthcare system service plan for the community served by the IHN-CCO. Now this community health improvement plan, or CHIP as we call it, was completed about a year ago and was submitted to the state, and it was adopted by the board and submitted to the state and passed. The impact areas that we narrowed in on were in the areas of access to care, behavioral health, chronic disease, and maternal and child health. Now, annually, we need to report on the progress of this improvement plan. And so we are doing this currently by going through the improvement plan from a year ago and asking key questions regarding each of the goals of the plan. And there's something like, I almost forget, 13 to 17 goals. And we're asking this question: if this goal were met, what would it look like? If this goal were met, what would it look like out there, not on paper, or not in terms of metrics necessarily, although it might include that, but how would it look like to the client? And so we have the next step after goals is outcomes. So we've listed as, and we are doing this in our county, in our county committees. That's where the work gets done primarily. And so the outcomes are listed, and then we look at some strategies to try to meet those outcomes. So we're very active. We're a very active a bunch of people, and the counties meet anywhere from once a month to some twice a month. So another task is to advise the IHN-CCO on strategies for engaging and educating the community to be involved in the planning. That's kind of a nebulous statement. I think that what we're doing tonight is part of that, but again, it's primarily done through the Community Advisory Council and the advisory committees. And then, very important, but probably the most difficult, is to advise the IHN-CCO regarding the health needs and concerns of consumers and the community, particularly for underserved populations, and the system's ability to engage and activate consumers as full partners in their treatment, recovery, and overall wellness, what we were talking about, Gary, the question you asked. And then proactively engaging the community to be involved in the issues. This last part is where we are really trying hard to develop the best way we can to engage with all you folks out there and all those folks that aren't here. And especially with our IHN-CCO members, our Oregon Health Plan members. So that's what we do, and we actually have a lot of fun. It doesn't sound, I can't make it sound very fun-like when I describe it, but we have, sometimes we get kind of angry at each other, or disgusted at least, and some people like to put other people on the spot. Well, that's not all bad. I think, Liz, held up, did you have a question, Liz, or you were just including yourself? Yeah, she's one of those people. So what would you have to put, not me on the spot, but these other experts that really do this stuff? Any questions? Yes. I'm going to call on somebody else to answer that question. That's a very good question, and I think we talk about it. Do we have any metrics to measure our performance? I don't know. But I think those are the questions that you, as a member of the Benton County Committee, should be asking in your committee, and that'll filter on up to the CAC. I think we talk quite a bit about engaging, like for instance, the Latino community. How do we do that? And we've done at different levels efforts to try to engage, but in terms of measuring our performance, I guess we think we do well when our chip passes the state and that sort of stuff. But again, that's kind of like the metrics. It's good to get the metrics, good to pass them, but does that really tell us what's going on out there with the client? We have to look at more than just those things. Yes. Okay, for the regional CAC, it's a 3-year term, and there will be turnover this summer. Now, how do you get on the CAC? You're appointed by your local county organization, basically the county health board. Administrators are sort of chair that. So depending on what county you're in, it would vary, but that's how you would, yeah. The council, I'm talking about the council, not the board. No, the council will, a third each year. Mm-hmm. And I, as the chair, I have a 3-year term. I didn't say, I also am on the governing board of the CCO. And I'm not just the liaison, I'm a full member of the board with all the same rights and privileges as everyone else, and responsibilities. But I have a particular responsibility. Any other questions? We are, if any of you are OHP members and are interested and can get your babysitting taken care of and those things, we would love to have you get involved with your county committees and then potentially also be on the regional board, regional council. We're short of people right now. I'm not sure, we have somewhere in the neighborhood of 12. I didn't say, there are 19, when we're fully staffed, when we have our full number, it's 19. And at least 10 of those need to be OHP connected in some way. Any other questions?
Yeah, good evening, everyone. It's a little warm in here, so everybody's hanging in there pretty good. I was told I need to take my tie off so I would be approachable. I assure you that you can approach me at any time. I don't bite. My day job, as was mentioned, is I'm the administrative officer for Lynn County. Been doing that for a while. I don't have a health background. Unfortunately or fortunately, I seem to know a lot more about it now than I did a few years ago. I was supposed to talk about the Regional Planning Council, and actually to me that's interesting because the Regional Planning Council actually started before the CCO started. A group of people got together to talk about how we're going to do this. As it happened, I was involved at the state, the Association of Oregon Counties, when the whole CCO concept was really happening. And so was involved with the legislative effort to try to get counties included in that whole process because we do have a health department and we are in that business. So it was very interesting on the front end of this because we started, I think, 5 years ago, something like that. So the Regional Planning Council, which I don't think that was the name then. It was a group. It sort of morphed and evolved, and so when you talk about the role, it has changed. As it happens, I was involved at that level. Now I'm involved at that level, and I'm also on the board, so I get to make or suggest recommendations to myself, I guess I could say. But if you would, it's sort of where everything comes together. There is nothing that you can't talk about or bring up or want to discuss, whether it's a pilot project or financially how things are going or how we're doing on metrics. As a matter of fact, the meeting we had last month, we specifically talked about metrics and what kind of things ought to be done to try to make sure we meet the metrics. The discussion about how do you communicate with members, how do you get members involved in their health. I mean, you're talking about what we're trying to do with CCOs is you're trying to change how all the providers in this system do things, how they talk to their patients, what they suggest, how they code things, because unfortunately, the world still goes by how you code it, because that's how the money flows. And if you don't code it right, it doesn't go in the system right, you don't get the money right, that part, truthfully, if you want to transform how healthcare is delivered, you really need to break the code, literally. And I mean that two ways, actually. So it's interesting, the planning. I would say it ought to be a regional coordinating council more than a planning council, because we try to make sure that all the pieces come together and get discussed, meet on a monthly basis, and make recommendations if we need recommendations to the board, which meets every 2 months. I got that right. Huh. I might even make it to the next meeting. So it's really kind of trying to pull everything together and talk about everything. We get, normally we get, Bill is back there in the back. Works for the state and works with CCOs, and so we get a report about what's happening statewide and what kind of suggestions might be made. And again, the question was asked about, are you talking to other CCOs about how they made the metrics? Yeah. But truthfully, from my perspective, the focus is on the long term. What are we doing as a CCO to connect with members, to make changes in their behavior, which is really hard, make changes in the provider behavior, which is in some ways almost harder. I don't know, it may not be true. But what you're trying to do is you're trying to change all of these processes and get it coming together and coordinated. And that's kind of where the Regional Planning Council is coming from. And even though I have a tie on, you can still ask me questions. Yes. I don't know that we've actively discussed that, but the question was, are we reaching out, going into schools, trying to do that? Clinics. One of the things we did talk about last month with adolescent WellCare is the fact that lots of kids get physicals for sports, but unless that's coded, so they're seeing a physician, they're getting examined, but unless it's coded right and entered it doesn't count. And so we talked about, is there some way to connect those dots, which kind of gets to where you're coming from. Because that's, a lot of kids get sports physicals.
No more questions for Ralph. That's a great lead in to Kim Whitley. Oh, sorry. Are you talking, so the question was, is it just philosophical?
Let me talk to that. I said that I'm not, haven't been involved. As it happens, I've been on there's an insurance pool in the state of Oregon for cities and counties that includes health insurance. And we started into a wellness program, fairly richly funded, and it gets back to the reward. What you're asking is, should we reward people for trying to improve their health? And my personal philosophy is improving your health is reward enough. You have to understand what the whole thing is all about, and you have to decide you want to do it. The experience with the wellness program, like gym memberships, the people that were already exercising thought it was great. The people that really needed to do it didn't. So we've boiled that down to some specific things like trying to do Weight Watchers, trying to do tobacco cessation, some very specific areas. But should you pay people to improve their health? Well, one of the things we're doing, and actually Kelly or Kim can talk about that, part of this whole thing with meeting the metrics and getting the money is that money goes back to the providers with messages about, gee, we could have got some more money if you would have. I suspect that's an underlying thing there. Thank you.
Yes, there is other ways to reward people. So my name is Kim Whitley, and I serve as the Chief Operating Officer for the IHN-CCO. And I'm here to talk to you today about the Delivery Systems Transformation Committee. So the Delivery Systems Transformation Committee is focused on transforming healthcare at the provider level. As Ralph had mentioned, changing provider behavior is a really integral part to transforming healthcare and achieving the triple aim. Within the IHN-CCO, we were helped in the development of this committee by the state of Oregon, because in 2012, the state of Oregon required our contract to have a transformation plan. A transformation plan that would speak to how we develop and enhance and facilitate enrollment into primary care homes, a transformation plan that talked about how we integrated traditional health workers, how we decreased disparities in healthcare, how we improved provider education, how we implemented health information technology, how we implemented alternative payment methodologies, and so on. So there is quite entailed. As a CCO, we decided early on that the delivery system, because it was ran by providers, and providers have a long history of how they develop care, that was going to be quite a culture change, and it really needed to come from within and from the providers themselves. And so we invited providers to our first Delivery Systems Transformation Committee, and we started meeting every 2 weeks. So we have been meeting as a provider community, and I'm not a provider, I chair the committee and I work for them. I just want to put that out there. I'm in no way a provider, but I facilitate this meeting every 2 weeks of an array of provider stakeholders across Lynn, Benton, and Lincoln counties. And we have participation from Lynn, Benton, and Lincoln County providers, the counties themselves, the public health departments, long-term care, the non-emergent medical transportation service, from Trillium Health Services, from physicians, from mental health providers, from the emergency medical services to hospice. So this Department of Human Services comes. So we have a wide array of providers who have come and have been coming every 2 weeks since 2012, coming together and talking about how we are going to achieve transformation. It's been thoroughly exciting and enjoyable to see the providers work together on how they're going to achieve this and the slow culture change that's been happening. This graphic, which is in your packet, is kind of a schematic or a diagram of that committee. It shows how providers are teaming up with the health plan to change the delivery system. 3 main areas have come out of the work that we have done. Primarily are when we went to implement this committee, we really jumped 100% into the concept of community impact. And community impact says that if you have a shared vision, that you can move faster and further and achieve more. And so our community impact is around the shared vision of the triple aim. And so I just want to make sure that we're all understanding what that is. That's making sure that care is delivered at the right place, at the right time, and at the lowest cost. So that's our shared vision, and it truly is a shared vision. At the end of the day, I've had providers stay and just keep talking. They're so excited about what's going on, and this is not a short meeting. It's an hour and a half every other week. Providers are coming, they're engaging, they're staying longer, they're having collaborative conversations, and they're coming up with great ideas. So we needed to have an avenue and an outlet for these great ideas. So the providers together decided to fund a pot of money that we call the Transformation Fund. And from this fund, we then, as the Delivery Systems Transformation Committee, we hear ideas from the provider community and we fund them. Well, I don't fund them, or the CCO doesn't fund them. The providers themselves fund their own ideas. And they've created a whole scale of how they measure the ideas. So it's, they try to be, it's their providers. So they try to be very by the book. They have a whole set of guidelines and criteria, and if the pilot meets these, then they approve it. And so last year, well, I believe it's on the back of this sheet, is a whole list of many of our pilots. It's not all of them, but it's many of them. And so you can read a short summary on most of them. So we've done a lot of work in that area over the last year. Another thing that's come out of the Delivery Systems Transformation Committee are grants. So when we, as a Tri-County stakeholder provider group, we started to get recognized from outside agencies for the good work that was going on. And people were calling us saying, why don't you apply to this grant? We think you guys would be good candidates. So we started doing that. And we brought in about $6 million worth of grants last year, or the last year and a half. And some of those grants, there's 2 of them listed on the back, but we have about 6 or 7. And that continues to happen. We continue to have outside agencies contacting us saying, you are a good candidate for money we're trying to give away. How exciting is that? And so within the IHN-CCO, we've developed a whole grants department to help support all these, the grants that we're involved in. And the third thing that's come out of the Delivery Systems Transformation Committee is work groups. And on the back of the sheet is listed the different work groups that we have to help support transformation. And you can see we have a alternative payment methodologies work group. They've been instrumental in developing our alternative payment methodology strategy. And I'm happy to announce that as of January 1st, we had an alternative payment methodology that was implemented in 3 primary care homes. We have a dental integration committee, which is working on integrating dental services at the primary care home. We have a health information technology work group, which right now is developing a health data tool to help and assist providers at the primary care home understand a more population health perspective of the member when they walk in the door. We have a health disparities work group, which works to address and ensure that members are not being discriminated against in their efforts to achieve quality health care. We have a traditional health workers subgroup that is focused on the traditional health workers and implementing and deploying them throughout our service area. We have a training and education work group to ensure that the good work that's happening in the delivery system is then spread through all the providers in our Tri-County area. And then most recently, our newest subcommittee is an IHN website committee that came about because we heard through the CAC and their good work and others that understanding what's going on within the CCO and having the ability to give us feedback on what's going on wasn't available or wasn't obvious to the community. So we're building this website to make sure that we can communicate and that we have two-way communication. So what's happening within CCO is getting out to everybody, and then the feedback from the community is able to get back in. And so we're very excited about that and are shooting for a new website by the end of the year. So that is the Delivery Systems Transformation Committee. So do I have any questions? Yes, Liz. Yeah. Right. So as a transformation committee, so the question is that some providers have processes and policies that aren't necessarily aligned with the goals of the CCO. Kind of goes back to your question on incentives and what are we doing to make sure we're aligned, and we're working on that. And it's not it's not something I was necessarily aware of, but now I am. Yeah. 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 Right. Mm-hmm. Yeah, so Liz is just giving an example of historical care from a provider perspective when providers are delivering care within a process that has built up over years, not in the scope of a population health perspective where you're looking at the person as a whole person, understanding their socioeconomic background, their environment, their family history, and all those pieces, and putting the member in the middle and saying, what's in the best interest of this member? How can we decrease the barriers to care and then facilitate a better health outcome? And that is a really good example you just gave, and an illustration of how far we have to go. Yeah. Yeah. You know, she said if we have to contract with them, maybe we should use that as leverage. And we've had that conversation at the Delivery Systems Transformation Committee about, do we suggest, because we report up to the Regional Planning Council, do we suggest to the Regional Planning Council that we leverage our contracting ability? And the Delivery Systems Transformation Committee decided that it was more important that we, at this point in time, given the 20,000 members that came on in the first part of 2014, that it was more important that we have as many contracted providers as possible to ensure access at this point. So that was their decision at the beginning of this year. So any other questions? I'm going to hand it back over to Kelly.
All right, so we are moving forward, and I wanted to make sure we had a chance to answer your questions, and I have some questions that I have written here, and I will go through those, but I wanted to see if there is just any questions that any of you have, given all that we've shared, if we haven't already answered them, for any of us here tonight. Sam? So the question was, since we're not getting 100% of the incentive funds, will we not be able to do, given that we didn't get those dollars? And I think from our perspective, we have never budgeted those funds in the normal operations of where we are because they're incentive funds. So from that perspective, they're not in our current budget, so to speak. Clearly what we do is we use those dollars, as Ralph mentioned, and we push those back out to the providers who deliver care to our patients and say, you helped us, on this metric, you did really good. On this one, you really need to work on. And so I would say there would be less dollars to help incent providers to change their behavior, but it's still a good chunk of dollars that we will do our best to make sure that we push that out in the way that gets us the best results we can. So the question was, is the incentive enough, right, to change that behavior? And I think that's a great question. I think part of what you heard around here is that we are actually focusing on changing the behavior regardless of the incentives and not necessarily just on those incentives. So I would say that's why this committee that's been meeting every 2 weeks for 3 years is really trying to transform the delivery system. And it doesn't necessarily just mean on OHP members, it's on the way from a population health perspective. And so it's an interesting question, and I'm not sure, really from that committee, I think they're very engaged, certainly those ones that come, on changing the care. And I'm not gonna say regardless of the incentive, because of course that's good, but I think what we're really trying to say is if it's sort of the right thing and it's the better thing, we should do it no matter what, because it does that, but I'm not naive in that either, and so we're really trying to find that balance between doing both of those, but it's a good question. Mm-hmm. Sure, right. And I mean, I would say that some of them are very much more engaged than others and see the value long term that it brings for how they run their practice, but some probably don't.
Well, and we did talk about this. We met last Thursday, right before, on the 2nd, July 2nd, and we did talk about the metrics and where we were, and they were very interested in improving them. And for a lot of them, it's not that the dollars aren't enough, it's their workflow. It sounds very simple, but it's their workflow. It's like, well, how do I get an expert done? You know, okay, I'm supposed to do it. I'm excited about that, and I can tell somebody to do it, but that's not necessarily me. And if somebody could just create a button, I'd push it for you, right? So a lot of it is really peeling back the layers of the onion of the processes and figuring out how do we insert that expert into a provider workflow to make sure it gets done. Huh? And make it, you know, I'm so glad you brought that up, because I do have to say, and this might be just my bias, but I know that some CCOs, to achieve the metric, are doing it in a way to achieve the metric, and not necessarily in a way that's sustainable. And it's really important to us, an organization, that we create long-lasting, sustainable solutions. So we don't want an expert in one office that's just two months of just, you know, doing it on every person that comes in the door. We want to create an expert process that works across the board in every office, because it's the right thing to do.
Yeah, I just want to clarify a couple things. That question you asked, not only are they asked to do a lot of new things and how do we do it, but at the same time they've had an influx of a lot more clients. And so I've talked to especially this one primary care physician, and she is very frustrated because she is having to do more work and more technical stuff, and she just without any more time, and it's very difficult. The other thing I'd like maybe you would clarify. We're talking about two funds, and it occurred to me that we might not all be clear on these two different pools of money. One of the pools of money is the reward for meeting the metrics. The other pool of money is the one that we use for the pilot projects, which are from another source. So maybe just say a few words for me, if not anyone else. And then, let's see, there was a third thing. I'll think about it.
Well, I guess I'll start by saying that Oregon Health Authority is a very good parent, because they are modeling what they want to see us doing. So, and by that I mean they are paying us our global budget, and they're holding some dollars back, and they're saying, you guys meet a quality standard and you'll get that money back. That's an alternative payment methodology. They're modeling that for us, and they expect us to then see that in how we're setting up our delivery system. So that is the metric dollars. That's the quality money they're holding back from us, saying that if you achieve these quality metrics, you'll get the money back. That's the metric money. The providers on their own voluntarily took a reduction in their reimbursement rates and created this funding pool to transform the delivery system. That's the second pot of money.
The third thing is you have criteria that you use for the pilot program. I think those would be interesting for you to measure, or to mention, you know, the things that you look at, for instance, the chip and the various things. So I don't think you mentioned that before.
I did mention that the providers have created criteria to measure the pilots, but what Dr. Eby is referring to, because Dr. Eby comes to the Delivery Systems Transformation Committee, what Dr. Eby is referring to is recently the Delivery Systems Transformation, we call it the DST, so I'm just going to refer to it as DST. The DST decided that we could do a better job aligning within our own committee. So we decided to align the metrics with the elements of transformation with the community health assessment. So now we're looking at pilots and grants and saying, how many hit marks on all of these, and where does that leave holes? So we have, for instance, we have a lot of pilots and grants that are about the integration of mental health and physical health. but we have very few that focus on chronic disease. And chronic disease is one of the things that the community health assessment points out that we need to focus on. And so the delivery system, the DST, is working right now to prioritize how we support things going forward, and what holes are there in either the metrics or the CHA or the transformation, and that's where we're going to focus our efforts going forward. Betty.
Next level of participation among providers. I mean, it sounds to me like I would love to be a little mouse watching the DSC functioning, because that sounds very exciting to me. Now, how does that excitement then reach out to the providers who are not there? How are they sharing their excitement, their willingness to try to change how healthcare is delivered?
I love that question. That's like DST2. We're just starting to have that conversation. How do we spread the word? How do we spread it faster? Because I think one of the metrics, things the metrics identified for us is we're not moving fast enough. So how do we get the word out? How do we get it out faster? How do we push? And how do we support? One of the things we need to understand, and I think Dr. Eby alluded to it, is this is not easy for a provider and their office. This is very stressful for them. A lot of them don't understand it. A lot of them are confused by it, and a lot of them see it as actually going backwards. And so how do we help support them in this change and educate and all those pieces? We do have our work group on training and education, but we feel it's not doing enough, and so that is the next thing for this year, the next focus. Anything else?
All right, should I read some of these? Are there more questions? You want me to collect more too? Okay. Any more? Okay. All right. So I'm just going to read them. So this first one says, I know metrics are in place for dental prevention services, sealants, for children, but what about dental prevention services for seniors? We know oral health is linked to heart disease, stroke, lung disease, kidney disease, and diabetes, and we can cut aspiration pneumonia in half with good oral care. How is this being addressed? So that's a wonderful question, and I think it goes back to fundamentally the whole discussion we've been having here today. So there is a new metric in 2015 related to oral health for children and sealants. There is not a specific metric related to non-adolescents and sealants, and I think that's a really good point of what do we do about that in our community, and how do we have a broader focus? And do we spend energy on a broader focus that has a broader outcome, or do we spend our energy on the metric that gets us hopefully a good outcome and the dollars? And I would say that's one we can take back, and that one that maybe the Community Advisory Council can give some thought to, how we can not turn on the fan, how we can get some feedback on what would be useful for seniors, as well as the delivery system transformation. How would that fit in terms of pilots? So I think that would be one that we would take back and work through that process. But I think that's a great example of a metric versus something that is a good thing to do, and how do you balance all those resources? So I hope I sort of answered that question. The next one says, will IHN pay for SamFit gym memberships for its members? Great question. At this point, that's not technically a covered benefit under the Oregon Health Plan. Again, IHN-CCO is wholly owned by Samaritan Health Services, but a very different management structure and a different organizational structure, and at this point that is not in place. But I appreciate that feedback, and it is certainly one that we would take back with us and see if there's anything we can do. Just put that out there. So there's a question about paying for acne medicine but not rosacea meds. I'm guessing this has to do with something that's covered in terms of the prioritized list and acne medicine. And I'd say that's one where we struggle a little bit, because although we're technically under a global budget and we're trying to shift this pendulum to more of a population health approach, we're still functioning under the rules of our contract with the state, where certain things are covered and not covered, so that creates a bit of an issue. But if there's a more specific question in there, somebody would like to maybe check with me afterwards, I can try and get a more specific answer around specific drugs or codes that are covered and answer that better. But I'm guessing that has to do with coverage on the prioritized list. When will doulas be paid? How will that work? More information needs to be available to OHP customers. I just learned about the shuttle, and I've had it for 2 years. I'm not sure what the shuttle is. Why are only some cards issued? My whole family is on, but only 2 have gotten cards. Great question. I'm guessing that's my new friend. So I think those are all great questions. When you talk about the shuttle, are you talking about non-emergent medical transportation? The non-emergent? Okay. So I think that's something that was new in the last couple of years, which is how long you've been on. We did send out a notice to all members, I think it was all members, letting them know that that was now a covered benefit. I don't know why you're not getting, obviously I'm going to check on that. So that was sent out that talked about the non-emergent medical transportation being covered and what it was available for and how to connect with it. So certainly something that we'll follow up with. I think doulas are part of our discussion as it relates to the delivery system transformation and additional focus on that and how we can do outreach in different ways. And I don't know if do you have anything else to add on that, but it is part of one of our committees is looking at doulas and how do they fit in and how can we look at that from a transformation perspective. Yeah. So we're just getting going, absolutely. And that's true, we don't have a plan. We're just working on collecting all the information, so you're absolutely correct. There's a lot more work to be done on that. I guess that's where we are, for sure, but an important piece. And then the cards issued. I honestly don't know if we try to issue mostly, less mail, but I will definitely need to check on that. I don't know that off the top of my head. Well, part of that has to do with the technicalities of how the enrollment happens through the state, and we don't always know who in every family is connected, believe it or not. So we're working on different ways that we can be more efficient. We've heard that one before. We used to have a family code, so we would only send one, and with all the changes in reform, that went away at a federal level, so we don't know how to connect we don't know who all is in the same family by the enrollment file, but there's an opportunity there that we're trying to think outside the box to be more efficient. Great feedback. But I'll follow up on the other ones with you directly. How can someone file a complaint about IHN-CCO? One of their children repeatedly got dropped from coverage, but the other 4 children in the household have continued coverage because of being dropped repeatedly. This child has not been seen by a dentist or a doctor in 2 years. Sitting on hold for hours at a time is not fixing the coverage. Okay. So I think that's certainly something if you want to let me know who that is specifically. Again, the challenge for us is that we don't do enrollment. The state of Oregon does all the enrollment. We just get the file and they tell us who's on our plan. So it sounds like this is something we need to help coordinate with whoever this is happening to so we can figure out why it's happening because it doesn't sound like it makes any sense. It looks like you're being put on hold for quite a long time at our extension that you put on here, whoever put that on here. So make sure if you are willing to let me know some more specifics and we can connect up somebody to try and figure out how to research backwards why the eligibility is being dropped, and we'll have to work with the state on that because again that's not something we do, but we can help. So come see me. Newport is building a new hospital. During the design phase, will Samaritan Health and IHN-CCO work with designers to create medical primary care home model clinics? Fabulous question. So, because the health district is building the hospital, not Samaritan Health is actually not the builder, right? The health district. So you all know, the hospital in Newport is owned by the community, by the members of the health district. They pay taxes and they support that building and that land. Samaritan Health Services has a contract to administer that hospital for that health district. And so they have just passed a bond measure to build a new facility. So certainly Samaritan will be involved in terms of feedback and insights on the facility. And we will do whatever we can to institute the transformational changes that would be most helpful from a structural perspective. But that would all need to go through the health district. But we are engaged on a lot of those planning committees, and that's a great reminder that we will make sure that we bring up. So that's all my official questions on paper. Are there other questions anybody has? Yes. Okay. Say it again, sorry. Yep.
I've had actually a really good experience with
Okay. So can you replay the question?
So the question was on care coordination and who can expect to have care coordination. So I'm going to answer it in a couple of different ways. Okay? Everybody should expect to have care coordination. It's an element of the primary care home. Everybody should expect it. Whether offices have those workflows in place to actually deliver it in the best way possible, they're all on a continuum. Some are really excelled, and some are just struggling to figure out how to make it work. So offices are going to be a little different that way. The other thing is that I think somebody mentioned how providers don't just see IHN patients, and the incentivization to care coordinate, it's a whole new language, isn't it, is only right now for some plans, not all plans. And so depending on how many members of what type of plan a provider has, they might be more advanced than others. Related to care coordination and mental health, which is on that other document, that has to do with an effort in Lynn County and the Lynn County Mental Health and their collaboration efforts at Geary Street Clinic with medical. So that's a pilot type of thing. It's been very successful, and I hear they're planning on expanding. I don't know if Frank's still here, but I put him on the spot because it's been very successful, and it's one of the things that we want to see grow faster and be spread across the Tri-County area. One of the things I want to say about pilots, because pilots start small, because you want to use minimal resources to see if you can gain grounds quickly and then measure, and if it's successful, you want to spread quickly after that. And our goals as a CCO is to create a standard of care that's the same for all members across all 3 counties. And there are a lot of work groups that we didn't mention on today that are the counties coming together in different ways to try to achieve that standard. And one of them related to mental health is the Mental Health Advisory Council for the IHN-CCO, and it's all 3 counties coming together to talk about how do we create, what is that standard going to be that members can expect to achieve. Care coordination in the office, I'm expecting that to be one of those things that they set up and that we will then strive to achieve. Everything, sure, her question is, where does care coordination originate? In the model we're trying to achieve, everything originates with either the member or the primary care home or referrals to the primary care home by other providers. So the primary care home should be the hub or the nexus of where everything happens and where all the information is related to us as members, so that when we walk in the door, all of our information is there, and the provider's been communicating, and there's seamless handoffs for us as members. I don't know about you guys, but I've cried too many times in this whole system trying to get my children, to be seen, or trying to address a problem, trying to get my bills paid, trying to do all these things, and it's extremely frustrating. Well, in the system we're trying to create, there's going to be all these connections that happen behind the scenes, and we won't experience. I live for the day we don't experience all that. Right? That we walk in the door and the provider has looked at my history and physical, not had me fill it out and then ask me all the same questions without looking at it. Okay, that doesn't make any sense, right? Or that says, hey, I saw you were just in urgent care yesterday and they did X, X, and X, so let's not repeat that today, right? So those connections are being done in the background, and when we come in, that's care coordination. So that all happens at the primary care home. Pharmacy services are going to be a part of that. Medication, yep. Medication adherence, compliance, reconciliation, very important. Huh? In the same, well, absolutely, in the same office. I hear your pain, right? I have to I get a prescription and then I have to figure out when I'm going to get it, how am I going to fit it in, when's the office open. It's a barrier. Yeah. Yeah. Right? And then you go get it and this happens, right? It's the wrong prescription. So then I'm gonna sit here and figure out how to cut my pills in half until I can get the prescription redone so I can go back and do it all over again, right? So yes, we're gonna solve those problems.
Well, on that note, yes.
I just want to give a pitch for the councils. All these questions that I hear, you know, you get a chance once a year here in Lynn County to have these people up here and ask questions. But every month of the year, councils meet in each one of our 3 counties. And there are members of each of these councils here, county councils here, and if you can't come to the meetings, talk to one of them. So everybody from Lynn County that's part of the council, raise your hand. Liz, you're one. Okay, those are the Lynn County people. What about Benton County? Did you all go home? Gary's from, there's one, and Sam was around here somewhere. Okay, you can go to them. And Lincoln County, yeah, I don't know if only the committee members are here. But anyway, this is where the action takes place between meetings in terms of client advocation. Is that the right word? Advocation? Anyway, advocating for the client, that's where it takes place on an ongoing basis.
Okay, getting back to the user. At the local committee meetings, we have users show up, they're confused, they're frustrated, and they might last a month or two, and then they're gone. For whatever reason, they don't have transportation or whatever. So I use your website, and it's pretty good, and I can find out some stuff, but I'm not sure that the actual clients use it. Have you thought about making little mini things on Facebook or YouTube or hiring a teenager to communicate?
I have 2 teenage daughters. I will definitely.
I mean, you know, if they go to the doctor, they get a slip of paper to say, join our Facebook page. And you can, you know, they need more information. Whether or not it helps with the transformation, I think that's one area that we all need to work on.
And I think you're absolutely right. And I think any discussions that you all have or have already had and can get that feedback back to us on things that might be useful, then we can figure out how we can or can't do those and get back to you. But any of that information is exactly what we need coming so that we know what might be the right thing to do. Absolutely. What else? I think we have like 2 minutes. All right. Please, there's more food in the back. Please take, oh, Betty has one final comment. Oh, okay. Do you want the mic?
I just want to say thank you. I think this has been a very interesting meeting and a lot of interesting questions and comments, and I appreciate it.
All right, thank you.